Hey, my name is Ryan Todd. I'm a paramedic at Johnson County EMS. Today we're going to go over bag valve mask, kind of talk about what it is, how to set it up, what we use it for, and some kind of considerations when you're operating this piece of equipment. So most bag valve masks will come in a large bag such as this. First step is going to be to remove it from the packaging. A lot of them will come kind of collapse down just a little bit to save a little bit of space, so you're going to want to pop it open. Sometimes this reservoir will pop off when you do that, so it's just easy, snaps back on. You'll have your oxygen supply line, the reservoir, the bag itself, and then some of them will have PEEP valves or positive end expiratory pressure valves up here. This model does not. The other piece you will have inside that packaging is the face mask, and that will just slide on to the front right there, and you can twist it, turn it however you need to best position yourself to help the patient. So BVM is used to provide artificial ventilation for our patients before we can get them onto an actual ventilator or get to the hospital or have to switch airway management methods. I'm going to apologize if you hear any background noise in an active firehouse right now. Not a whole lot I can do about that. So to set up this piece of equipment, you're going to make sure that you have your mask attached to the bag. If your agency uses CO2 connection devices, that's going to go in between the mask and the bag itself. It should just slide right over the pieces and fit together kind of like a Lego set, is how I've heard it described. Next step you're going to want to do is take your oxygen supply tubing and make sure that that part is connected to your oxygen tree, whether it be from a portable cylinder or in the back of a truck. They'll just slide right over. Oxygen settings for that will be 15 to 25. I've seen it both. Make sure that once your oxygen is flowing, your tank is open, you've got your regulator set where you need it to be, that the reservoir bag is filling up with air. And from there, we're going to get into how to put it on a patient and adequately give them the oxygen they need. So the indications for bag valve mask usage are pretty broad. It's going to be any patient who's not adequately ventilating themselves. Could be due to respiratory cardiac arrest, could be due to altered mental status. They have some form of disease process that's hampering their ability to adequately ventilate for themselves and get that gas exchange. Contraindications are obviously patients who are adequately ventilating themselves. They don't really need us to breathe over them. That includes people that may have a rapid rate, but they're still maintaining good oxygen saturations. They still have decent end-tidal CO2 readings, such as your DKA patients. They may not necessarily need us to assist them with a bag valve mask, even though it may look like they're not breathing effectively. Another contraindication will be if the patient is not tolerating the mask or the pressure. I have had it in a situation where a gentleman was not breathing on his own very well, and as soon as we would put the mask on his face and start breathing for it, he would start breathing again and smack the mask off of his face. So just something to look out for. Some patients may not tolerate it like they need to. So to apply this piece of equipment and use it, you're going to make sure that it's prepared. We've got our oxygen tubing, it's connected to the bag, we're connected to our source. Make sure our reservoir is filling up with air. If we have it, our CO2 connector in between the mask and the bag itself. Ideally, when you're going to apply with just a mask seal to the patient, you're going to want a minimum of 2 people. One person is going to be in charge of making sure that they're squeezing the bag at an effective rate, in an effective time and volume delivered, and you'd want another person to be holding a seal on the patient's face, using a jaw thrust technique or a head tilt, chin lift, whatever is appropriate for the situation. When we first get on scene, a lot of times we don't have enough hands to have 2 people dedicated to an airway. Your partner may be doing work in the cardiac monitor, establishing IV/IO access, any other number of tasks that we have to get done for patients who are going to need a bag valve mask. So we have our one-person technique, which is going to be done with your left hand. You're going to create a C with your thumb and pointer finger on the top of the mask, and use your remaining 3 fingers to grab the patient's jaw and try and lift it into the mask while you're applying downward pressure with the mask itself. This is a difficult skill for a lot of providers to do, whether it be they're not strong enough, they don't have big enough hands, the patient anatomy just doesn't allow us to get a good seal, whether they have a lot of adipose tissue, short neck, anything of that sort. So it's really recommended that you try and have 2 people to do this skill if you're going to just use a mask. So we've created our EC clamp. We are pulling the patient's jaw up, pushing the mask down, and we're going to give the bag a nice easy squeeze. We're not trying to go super quick. We're not trying to compress the entire bag into this patient's lungs at once. You may have heard it referred to as a firefighter squeeze, where you see them with 2 hands and they just press very hard and very forcefully. This can cause a lot of barotrauma issues to the lungs. It's also going to result in significant gastric inflation. So we really want to focus on the nice, easy inhale and exhale. So once we've got our good soft squeeze in, getting maybe about half of the bag in, you don't want to continue to squeeze it as it's reinflating. You want to let it get to a full reinflation before you deliver that next breath. The way to determine adequate tidal volume is we want to watch for chest rise and fall when we deliver that breath. So as we're squeezing, we want to make sure that the chest is rising, and as we're letting go, we want to watch the chest wall kind of go down. We're attempting to simulate the best we can for patient's own respiratory rate and status. So a lot of times after we've got more help on scene, if we need it, we're going to switch to a more definitive airway device, whether that be a biad or an ET tube or OPA, NPA. We're going to focus on ET tubes and biads for a minute, because that procedure is going to change a little bit over our mask use. So let's say we've got our patient, we've established that they have a need for us to breathe for them via BVM, and we need to secure their airway. So in this scenario, we're going to talk about an iGel. That's what our service carries. That's what I'm familiar with. It may be different where you work. So we've established that we need to secure the airway. We have placed our correctly sized iGel into the patient. What we're going to do then is take the mask off of the bag valve mask and set that to the side as a rescue device in case the iGel stops working, it's incorrectly sized, incorrectly placed, any number of things that could happen. We want to have access to this mask, and we don't want it to go missing. So in the case we have to pull that biad out, we can switch back to the mask and ventilate the patient like that. So we've got our bag with just this connector on it. It should have a CO2 device as well that will slide right over the top of your iGel. And as we're confirming placement, we want to listen to lung sounds, make sure that those are present. We want to hear no epigastric sounds, so no sounds of air moving in the stomach. And we want to also make sure that we have a good end-tidal CO2 waveform on our monitor with good CO2 numbers as well. This procedure can be a little bit different if your agency is using colorimetric devices. In that case, you're going to want to check your paper in the device itself and make sure it's changing color from whatever the air color is to whatever the CO2 color is. So once we've confirmed our placement on our device, we're going to secure our airway device as best we can, whether that be with a commercial or a improvised technique. Could be tape, could be a strap that comes in the packaging, could be the infamous tube tamer that we've all messed with. Our squeezing technique at that point doesn't change a whole lot. I still like to keep my hand kind of on the device as well as the bag to make sure that I'm not getting a lot of movement from the biad itself, and just kind of as a secondary means of securing it, making sure it's not getting dislodged. Our squeeze is still going to be the same. It's going to be one-handed, nice and gentle. Squeeze down, let the bag reinflate. Rates for how many times per minute we're supposed to be ventilating can go from 10 to 16. A good number to keep in mind is we want to give one breath about every 5 to 6 seconds, and want to deliver that inhalation over about 1 second. So it'll be, I like to count because I'm a numbers guy. We got 1, 1, 2, 3, 4, 5. 1, 1, 2, 3, 4, 5, and so on and so forth. We can determine how effective our rate is, and we can adjust from there looking at our SpO2 number, our CO2 waveform, and our CO2 values on the monitor. So now that we've kind of covered how to use this in ideal scenarios, we're going to talk about some considerations for use of this equipment. So the adult BVM is kind of a one-size-fits-all. Patients are not one size, and not the same solution works for every one of them. So we talked about calculating a rough, correct tidal volume. So the way that tidal volume for ventilators is assessed and figured out is they go through with the patient's ideal body weight to determine how many milliliters of air they need to properly perfuse and ventilate. So the adult BVM is about a 1 liter or 1,000 milliliter size bag. There are very few people, if any, in the world that are going to need a 1 liter tidal volume delivered. Most of us are going to be within the 500 to 600 milliliter range, which is going to be about half of this bag, which is why I prefer this one-handed technique. It delivers just about half of the total volume of the bag per breath. And that can change if you're talking about pediatrics or anyone of smaller stature. There is a separate BVM for pediatrics that's a much smaller bag. It's about a 500 ml main bag, has some different size masks. There was some research that came out that said that we should be using pediatric sized bags for everyone because it helps us deliver the more appropriate tidal volume. Most recent research has shown that that wasn't really true, and it may have actually been hurting people. So it goes to show, do some of your own research when you're talking about these kind of topics. One of the other considerations on using this device is running a bag at 15 to 25 liters per minute is going to drain your portable tanks very, very quickly. If you have a full 2,000 tank of oxygen, you're going to get maybe 10 to 12 minutes off of that at 15 liters. So if we're sitting on scene and we're having to stay and play a little bit, it might be worth having to send somebody to get some extra tanks if need be. Your main tanks in your ambulance will be a little bit bigger, a little bit better on air consumption. You'll have a little bit longer on them just because they're bigger tanks. It's how physics works. So we're ventilating, and all of a sudden we're getting some increased resistance on the bag. It's not as easy to squeeze. We may have a drop in SpO2 values. We may have issues with the waveform on our CO2 being different, non-existent. For that, we can use the mnemonic DOPE, which comes from ventilator management, some critical care people. It stands for D, displacement. So did our tube get displaced? Is something in the stomach, something not connected in the circuit between the bag, the device, and the patient? We want to check that first, make sure everything's okay. This can also go to checking your CO2 connector on your monitor or your SpO2 probe, make sure it's actually on the patient's finger. Obstruction, is there something in the tube or the BVM that's making it difficult to squeeze? Could be vomit, could be airway secretions, could be any number of gross substances that happen when you're managing airways. So for that, you want to make sure that you've got suction ready, prepared, nearby, because it's probably going to come up at some point in the process of managing this patient's airway. The P in DOPE stands for pneumothorax. We want to make sure that we haven't developed a pneumothorax, whether from overzealous BVM technique, delivering too much tidal volume, could be a traumatic patient that is unconscious. Any number of scenarios could cause a tension pneumothorax to show up. So you want to take your steps to rectify that, whether it be a needle decompression, finger thoracostomy, chest tube, whatever device you have to make it work. And the E stands for equipment failure, and that kind of goes back to the displacement. Did the bag break? Did our reservoir back here pop off? Did the oxygen line pop off? Did the tube slide around? Did the monitor die? Any sort of issue that you could have related to equipment.